Hi, everyone. Welcome to our first lecture in our series of 4 lectures on narrative reviews. All right, let's go ahead and get started. As we jump in, I will briefly introduce myself so you know who is talking to you over the next 4 weeks, and then we'll hop into a little bit more of a broader picture about kind of why we do research in medicine in the first place, and we'll slowly make our way towards kind of what a narrative review is, why we do them, and we'll get started on thinking about kind of what constitutes a good research question. When we think about narrative reviews, what does the structure of a research question for a narrative review look like, and things like that. So traditionally, this lecture series has been kind of jam-packed. We don't stop a ton for questions, but if you do have a question, by all means, drop it in the chat. And if we don't get to it live, I will absolutely get to it at the start of the following lecture. So let's go ahead and get started. So I'm Dr. Sarah Waters. I have a PhD in behavioral science, behavioral economics from the London School of Economics. I'm a Canadian, and right now I live in New York City, though I lived in London for many years. I've really spent my career at the intersection of healthcare and patient behavior, and I've spent really the last decade or so working in technology, so digital health apps, health tech, things like that, all with an eye towards behavior change. And as you'll see in a second, my guest star is this gigantic 100-pound Bernese Mountain Dog who sniffs a lot, walks really slowly, and gives me a lot of time to contemplate impatience and also how my brain works and our brain works. So that's a little bit about me. So you know who's talking to you over the next couple of weeks here. All right, so why do we do research in medicine at all? I mean, everyone here has gone through med school or is in med school, so it's really no shocker to anyone, but we'll run through kind of two different kind of views, which will dive us into our next topic. So how do we care for those who need it? How do we care for our patients? What treatments do we offer and do we prescribe to them? We need to do research to understand how we should care for our patients. What's the best way to care for them? How do we know what that best treatment or care plan is? And how do we know if that treatment or care plan is working for that particular patient? How do we know if the treatment that we provided to one patient is better than another treatment that we could have provided? These are all questions that we need to do research to answer. And then, yet again, how do we know if the best treatment that we give to one patient is the best treatment for another patient? So the patient we saw today is the best treatment also that we give to the patient that we see tomorrow. So again, more research questions, a ton, even just from thinking about one single treatment, one single kind of therapeutic area or disease type. So these are all kind of clinically oriented questions. A lot of these questions that we see on this current slide, we would address through what's called primary research. And we'll talk about what that means in a second, but primary research is really going out and gathering that data firsthand, evaluating how does one patient react to this intervention versus another patient, and gathering that firsthand data. We'll talk about that more in a second, though. So we have these clinically or treatment-oriented questions. And then if we look at things from a totally different lens, when we think about, oh, I got auto-muted. That's timely because the question I was about to jump into, I mean, we just looked at a bunch of clinical oriented questions, but we can think about doing research in medicine from a totally different angle as well. For example, what do we know about the use of AI in radiology diagnostics? Is AI better at detecting anomalies in some cancer types than others? These are also fair game questions when it comes to doing research in medicine. But as you can see, they're positioned slightly differently. What does the available data tell us about social support through immunotherapy treatments? So again, not really how does this patient respond? I mean, this one was a little bit, I cheated, but a little bit of a different lens than the questions that we saw in the previous slide. So a sub-question might be, do married people or people with adult children who live close by or near them have better outcomes than those who don't when they're going through immunotherapy treatment? So these questions really attend to, unlike the ones in the previous slide, really a broader understanding. What do we know? It's kind of the giveaway in that first question. What do we know about that topic? What is the state of our knowledge? Where are the gaps? What patient populations do we understand and which ones don't we understand? And that helps us inform where we need to go next. So when we talk about kind of what our broader understanding of a topic is, that tends to be, so in the previous slide, we talked about primary research. This tends to be secondary research. And we're about to unpack what those two terms mean, just so we're starting off on the same ground. Apologies if this is repetitive to some people, but just want to make sure we're kind of baselining across everyone before we jump in. So doing research in medicine signals to others. You can critically assess information. Doing research is a really good thing, which is a very, very much of a confirmation bias thing. I've done a lot of research, so obviously I think it's a good thing. But it shows you can review and synthesize what you know or what we know on a topic. And as we'll talk about through our series, it's not only that synthesis piece, which everyone on this call knows is table stakes at this point in the universe. There's a lot of things that can do a lot of synthesis really quickly. But it's also pointing out the strengths and the weaknesses, which really is where you as clinicians and you as experts in your particular areas of expertise, that's where your difference will be in your narrative review. It won't necessarily be in that summary piece. It will be talking about, well, why does the summary look that way? And we'll jump into that a little bit this lecture, but certainly throughout the series. So doing research in medicine shows you can think critically, which everyone on this call already has. So that's why you're here. It also shows you can articulate complex information in a simple manner. So when you're doing research, particularly reviews, it shows that you can take a large body of information and slam it down into a few kind of bite-sized paragraphs that ideally make a lot of sense and flow nicely together. And we'll talk about how to construct kind of the body of your narrative review in roughly probably lecture 3 or so. And doing research, you're able to drive your field forward. So when you do a PhD, they talk about imagining a piece of pie and you inching one single sliver of pie like half a centimeter forward. It's kind of the same thing when you're doing a research paper. You're moving the needle a little bit forward in what we know, what kind of humanity knows about what's going on in that area. That tends to be when you're going out and gathering data, but when you're doing a review, what you're doing is you're enabling us to move forward. You're identifying really, hey, what don't we know? Here are some hypotheses based on what I know best as the expert in this area. And here's where I think we should go out and gather more data, where we need to further our understanding very specifically. So you've identified a gap in our understanding of the study being primary research, or you're able to find an area to review that would benefit from our attention, which is really why we're here to talk about that second part. So that's where we start, is finding an area to review that would benefit from our attention. And our attention meaning kind of the broader medical community, the broader society. Again, what don't we know that we should know more about? And that's what we're going to do in our narrative review. All right. So by the end of the lecture series, you'll know what a narrative review is. Hopefully you'll have a pretty solid feel after today. If you don't understand this by the end of the lecture series, please let me know. Why narrative reviews are different from other reviews. We'll start talking about that today, and we'll revisit it at the start of every lecture series just very quickly to help orient you to say like, hey, I'm doing a narrative review, and here's why it's different from like a systematic review or a historical review, just so you know where you sit. Context is really important in all things in life. What is a narrative review and what are its strengths and weaknesses relative to the other types? We'll talk about that a little bit. And then lastly, when are narrative reviews your ideal tool? So when is it best to reach for a narrative review versus doing another type of research? We'll cover that too. All right, that's a beautiful slide. So as we talked about, we're going to talk a little bit about primary research and secondary research for a second here. So primary research means, again, going out and gathering data firsthand. Remember on that first slide, we had a bunch of clinical questions. How do we know if that treatment works better in patient A versus patient B? How do we know that treatment 1 is better than treatment 2? We need to go out, we need to gather that data firsthand. And so what primary research does is that it provides the data that we need, and that ultimately gets reviewed in secondary research. So things like narrative reviews. You're about to have a gigantic visual pop on your screen that we'll walk through. So when we think about primary research specifically, so going out and gathering that data firsthand, there's something called an evidence hierarchy, which is not on the slide because you don't need to understand that fancy term. Just understand that at the top of this used to be a pyramid, it's not a pyramid anymore. At the top of the visual, randomized control trials is really where, how I narrate it, the recipe is the strictest. So you need to have all of the ingredients intact in order to conduct a randomized control trial properly. And as we go down from randomized control trial to interventional and then observational through case study, what happens is that that recipe, the ingredients that you need to do those types of research, they loosen up a little bit. So the randomized control trial is really kind of the gold standard. I'm sure a lot of you have already heard of them or read through a whole bunch of them. The gold standard of going out and gathering data, because what it does is it controls for a ton of different factors simultaneously, meaning that we can be more confident that what we observe is due to the intervention that we were trying to observe the effect of in the first place. So by controlling for a whole bunch of different things, we can be more confident that A leads to B. Whereas if we didn't control for as many things, we might say, well, A seems to lead to B, but we don't know because there's a few other things floating around that might have interfered. So I'm going to run through these pretty quickly because I know this is a series on narrative reviews, but again, just laying the land. So interventional looks at actively manipulating a variable in order to see what happens. So we might have a whole bunch of patients come into the ER, and then we give half of them a particular treatment and then the other half standard of care, and we observe what happens to the patients who we give standard of care to and what happens to the patients where we give them this particular intervention. Observational simply looks at outcomes. We're going to look at a few examples in a second. Here I am, I forgot that I included examples. And then case study usually focuses on kind of one or two patients. Again, you've probably heard these terms. They usually tend to be relatively sensational in the sense that they're unusual. Patients might present with a kind of a constellation of different symptoms, and then they end up getting written up because we say, wow, we've never seen that before, sort of thing. So quickly stepping through some examples here, randomized control trial. So patients with hypertension are randomly assigned to either a new blood pressure med or a placebo for 12 weeks, with BP being measured at regular intervals to compare the effectiveness. Was the BP medication more effective than the placebo? The key for randomized controlled trials, which I nerd out about, is the randomization piece. Obviously, when you know people are put into different treatment groups, sometimes you might end up subconsciously or intentionally treating them differently as clinicians. So that's why that randomized piece is really high value there. Interventional, so all patients admitted with acute stroke receive a new clot-busting drug within 3 hours of symptom onset. And then the researchers track their neurological recovery over 90 days. So they're giving the intervention, and then we watch what happens. Observational, this one remains significantly relevant for me, it feels like, with the coffee consumption. Researchers, so we're not intervening here. What we're doing is we're simply observing. We're watching 10,000 adults over 5 years. We're tracking their coffee consumption habits, which, if you're anything like me, are off the charts. And then we're also looking at data on cardiovascular incidents and things like that. So again, no intervention, we're just watching. And then lastly, imagining, again, that sensational case, maybe a 45-year-old woman presents with a rare combination of symptoms. And ultimately, we realize, well, there's this unreported genetic disorder that we've really never seen among anyone before, and we managed to find it among this woman, which is unusual. So in that case, we write it up as a case study where it's probably only one or two people. All right, I rambled too long on the slide. Let's move on to secondary research in a second. But when I think of primary research, think of new, and then secondary research, we'll think of review. So literature reviews, that's where we look at the data that we got through all of those methods that we just walked through. So another monster chart here. Cochrane review, and then moving downwards, just like on the previous visual that we saw, at the top, that recipe is the strictest or the most rigorous means of doing research. Also, as a result, they tend to be the most arduous, they take the longest time, and they're the most resource intensive, which means that when you do research, whether it's primary or secondary research, you often will not honestly go grabbing for the paradigms at the top of these charts. You probably won't always go for a randomized control trial or a systematic or Cochrane review because they take a long time. They are very resource intensive. So at the top, the Cochrane review and the systematic review, again, you've probably heard the term systematic review. Cochrane review is just a type of systematic review. If you look up Cochrane review, there's a massive thing, is what I was going to say truthfully, called the Cochrane database, full of that specific type of review. Systematic reviews are what we call exhaustive, meaning you have systematically gone through all of the available evidence on a particular topic, which is why it takes a long time. Do we need these types of reviews? Absolutely, yes, we do, because we need to understand, looking at everything that it possibly exists on a topic, what don't we know? Can we do that in other ways through things like scoping reviews and narrative reviews? Yes, absolutely. But again, it's just that we might be missing something. It's very possible, though, as an expert, through a narrative or scoping review, you have a good idea, though, of what might be missing in your particular area that you think we should research next, which is why you don't always need to go grabbing for a systematic review. So scoping reviews, moving down quickly. So systematic review is really exhaustive. You do everything. Scoping review typically looks at kind of what's out there. That's the purpose of a scoping review. What do we know? What don't we know? The end. A narrative review is slightly different and it's very similar. So we'll look on the next slide at the more nuanced difference between the two. But narrative review can also be used to look at gaps in literature, but it's also used to do more. So you're typically looking at what exists, what theories can you think of that can help explain, well, why does that literature look the way it does? It's more almost introspective in a way. You're not just saying, here's what exists, here's what doesn't. You're saying, well, here's what exists, here's why I think the evidence base kind of looks like this. Why do these studies disagree with one another? We'll talk a little bit more on that on subsequent slides, though, today, as we walk through what that kind of narrative review looks like and the core elements of it. And then lastly, at the bottom, the historical review. Not rocket science, you're looking back in time at a particular concept or a particular therapeutic approach or way of treating a particular condition, for instance. So we'll zoom through a few examples for each one of these. I know these are really data or kind of text-heavy slides, but the slides will be available afterwards. It's just a matter of me not being fantastic with diagrams. So a Cochrane review, you can think about it as antibiotics for acute bronchitis, a systematic review and meta-analysis comparing antibiotic therapy versus placebo. And an important point to point out for this one, and then the systematic review, you're probably wondering, where does meta-analysis fit in? And if you're not, welcome. Meta-analysis are typically chalked up there with systematic reviews. And if you don't know what a meta-analysis is, it's really looking at the quantifiable or the numerical outcomes. And what essentially a meta-analysis does is it pins all of the numerical or numbers from the different studies, essentially, different outcome values, against a common backbone so that you can say, hey, looking at all of these together, because one study, for instance, using a very kind of easy example, one study may say, rate something on 1 to 4, and the other one says, we'll rate it from A to B, and the other one says, we'll rate it from 1 to 60. You need to be able to compare those to one another, and that's effectively what a meta-analysis says. It says, oh, okay, let's take all of those disparate or different scales and pin them against a common backbone, and then look at what we're getting. So those typically sit up with systematic reviews. So those are two different examples. And then going down to scoping review, which again, is used to figure out what don't we know. So what interventions exist to reduce hospital admissions in heart failure patients. So a scoping review is mapping the breadth of available evidence. What is available? And then conversely, what is not available? What don't we know? Narrative reviews, again, a slightly different flavor from scoping reviews. So current approaches to managing type 2 diabetes and primary care. So an overview of pharmacological options, lifestyle interventions, and emerging therapies. So it's a bit different again from scoping a review. We're not just saying, hey, what exists? We're saying, let's look at a few different pieces of this particular topic and weave them together in a narrative that makes sense. And then historical review, the evolution of insulin therapy from animal extracts to modern analogs, tracing 100 years of diabetes treatment innovation. So I know these are super text heavy and I'm kind of rambling through all of them, but again, just hopefully now it makes a little bit more sense where narrative reviews sit within kind of research, all of research more broadly. So the primary research that you'll be pulling on for your narrative reviews, because when you go to do your narrative review, you'll need to go back and figure out, well, do I want to use randomized control trials? Do I want to look at studies that are interventional? Do I want to include case studies? And we'll talk about your ability to discern kind of which ones you want to include and also exclude in your narrative review, because that's actually one of the levers and one of the beauties of the narrative review, since it's not a systematic review, is that you actually end up getting to pick and choose what you want to include in your review. We'll jump into that a little bit today, and then certainly again in subsequent lectures. So I keep going back and forth between scoping and narrative review because they're very similar. We'll look quickly again. So again, primary is new, secondary is review. We'll look quickly at the key differences between the narrative and scoping review. So narrative reviews, if we go down to that key difference instead of that top key difference, that's a really good slide, Sarah. The bottom key difference, the narrative review asks the question, well, what we know, and then it seeks to make synthesis. So we're summarizing and then recommending. What do we do next? Whereas the scoping review, again, looks at what research exists and then seeks to map out the landscape. So 2 sample questions above. For a narrative review, you might, for instance, ask, what are the best practices? What are the current best practices for managing heart failure in clinical practice? And then a scoping review question as its analog might be, what is the extent and nature of research evidence on telemedicine intervention for heart failure patients? So there's slightly different flavors. All right, you're also like, Sarah, what is a narrative review? So let's unpack what more specifically kind of the key components of that narrative review are. So a narrative review, again, it's a broad overview. Truthfully, I find one of the biggest challenges of teaching this narrative review lecture is that they are very broad and kind of amorphous in a way, meaning they take on different shapes, particularly because you can do a narrative review on so many different topics, which is why I give a lot of examples. Hopefully, at least some of those examples resonate with some of you. A lot of what we talk about is going to be dependent on your topic. For instance, if you are focused on rare diseases, some of the stuff we'll talk about, and I'll try to narrate it as we go through, but some of the stuff we talk about will shift a little bit versus if you're focusing on kind of a very broad, vast kind of literature of kind of cardiometabolic stuff. All right, back down from my soapbox for a second, but a narrative review is that it's a broad overview of a subject. And what I mean by broad overview is it's non-exhaustive, so it's not everything. We're going back to our secondary research visual that we just saw, systematic was exhaustive, it was everything. That recipe is strict. Narrative review, the recipe is a little bit looser. You can kind of, I don't know, pretending you're in the kitchen, you're no longer kind of baking a cake that's not going to turn out. If you forget the baking soda or baking powder, you're now just kind of cooking. And if you need to sub out an ingredient or omit one, you're totally fine. So broad overview is non-exhaustive, non-everything, and then non-systematic, meaning your own playbook. And we're going to spend another slide or two talking through more specifically what I mean by these. your own playbook is very vague, but it just means there's not necessarily that recipe that strictly needs to be followed. You, as the researcher conducting this review, again, you get to pick and choose how you want to conduct your review, mostly referring to what you want to include and exclude, but there are a whole bunch of different parameters upon which you can decide to include and exclude things, which again, we'll talk about in the next slide or so. So narrative reviews, the way I think about it is kind of two different pieces that are bolted together. The first one, again, being that summary piece. So we need to tell our reader, hey, what do we know about this topic? What are the findings from primary research, or what are the findings in general? And then what do we think? What do I think as the expert writing this review? What do we think about those findings? Why don't certain authors agree with one another? Why don't certain quantitative findings point to the same thing? That's that critique piece. So I think about a narrative review effectively of being those two pieces bolted together. And then narrative reviews almost always conclude with a gap identification. So again, here's a summary, here's what I think of the summary, and then what don't we know? Where should we go next? What is the future direction? What primary research could be run so that we know more about XYZ? So that's probably not a good headline, but we talked about them being non-exhaustive in nature. So that means that you, as the researcher, you get to decide things called inclusion and exclusion criteria. So for instance, you might say in your narrative review, you want to limit it to peer-reviewed journal articles, which is kind of the common default. It's worth calling out at this point, there's a lot of decent research that is not yet peer-reviewed or might not be peer-reviewed. So research that's done, for instance, by public or private companies, when you think about like gigantic consulting firms, for instance, they do research all the time that's not necessarily peer-reviewed. Again, that's a piece that's going to depend on your topic. If you're doing a hyper kind of clinically focused narrative review, it's very likely you will only have peer-reviewed research. If you're doing something that's more public health oriented, or maybe has some sort of kind of social outcomes, maybe social determinants of health flavor to it, you might end up bringing in research that is not peer-reviewed. So you can start to see why it starts to be a little bit of a choose your own adventure kind of situation. Other things that you might include, looking at this one kind of lens of inclusion and exclusion criteria, which is what type of materials are you including? You might come across meeting abstracts or preprints, so publications that might eventually be peer-reviewed, but maybe not getting into those journals until kind of 8 months from now, conference posters and things like that. So just gives you a little bit maybe wider of a lens to think through, hey, do I want to include all these things? Do I want to purposely exclude some of them? Again, we'll come back to these criteria throughout the lecture series. Predicted the future by my own bullet. So that was non-exhaustive in nature. The other piece was that they're not systematic, so that recipe is not strict for every narrative review you will ever do. There isn't a 1, 2, 3, 4, 5. You need to have all of those things all the time, regardless of your topic, which is truthfully kind of the flavor for systematic reviews, which is why they are logistically challenging. Non-systematic means often in the method section in narrative reviews, depending on the journal that you're submitting to, they're going to have different requirements for what you have in that methods section. And that's really the methods is the recipe. How did you get to where we are in this narrative review? What did you include? What did you exclude? How did you review what you are talking to us about? There are different ways to review things, which we'll talk about in probably lecture 2 or 3. Things like extracting common themes and things like that. Ultimately, though, the journal that you submit to is going to have probably a different shape of methods that they require. Throughout this course, I'm going to talk about methods in a decent amount of detail, just because I personally think it's important to build out your understanding of how to do methods properly, and then whether or not they ask for the detail in the journal itself is kind of an after the fact consideration. At least you have the map that you followed to get there. And then you can extract the level of detail that's important or not. I also think it's important to know exactly and be rigorous about your methods, because someone might come along and say, well, I want to replicate your research, and you should be able to show your reader, hey, here's exactly how I did it, want to redo it. Not only redoing it, but do you want to build on it? So they're not necessarily saying, well, I think Sarah did this, like I'm not totally sure, it's unclear, she's very vague in her methods. Instead, they can say, this is exactly what Sarah did in 2025, and I'm going to improve on it with the most recent literature in 26 or 27, sort of thing. Again, I just need to stop talking and actually show the bullets here. It's beneficial to show your reader why you might make certain decisions. Why did you choose to exclude preprints or conference posters? Why did you decide to include a report by McKinsey or a report by Boston Consulting Group? All right. So again, here are those two kind of key kind of core competencies, as we'll talk about it for the narrative review, that summary piece, and then the critical appraisal piece. And we're going to spend kind of the rest of the lecture talking through, I think, let me cheat for a second. We're going to talk through kind of what these two things are, and then dive into, well, how do I even come up with a good topic or research question in the first place? So we're still looking at the building blocks, and then we're going to come out at the end of the lecture talking about, well, then what? How do I come up with a good research question? So summary, what are the studies telling us? And then that critical appraisal, why are there inconsistencies in our findings? Where are the methods different, and what hypotheses can you make as to why the summary looks the way it does? Why do certain studies agree with one another? Why does that treatment seem efficacious sometimes and not other times? Those sorts of things. So we're going to look at a monster table, which I've tried to break up a little bit. On the far left column, we have component. So those are just things, considerations really. And then the summary piece. So what the author does, which is me and which is you. For the summary, you're describing what's known, you're presenting the findings. You're saying, well, author A found this, author B found this. Going back to why it's important to do research and do research well, you're being very succinct as you do this. You're showing the reader, hey, I can take a large body of information, I can slam it down into a few digestible paragraphs. So you're not going through the findings one by one and explaining everything forever. You're providing a nice summary. A very key part of narrative reviews is organizing the information in a way that makes sense to the reader. We'll talk through that as we go through the lecture series, a few different principles on how you might want to organize the information, whether it's from kind of most recent to least recent or least recent to most recent, whether it makes sense to cluster it together by gender or comorbidity. Again, you can see it's going to depend on what your topic is, wildly so. So hopefully we can provide a few illustrative examples that are good jumping off points. In the summary, what you'll also do is identify patterns. So again, are you finding that certain studies agree with one another in their results, or are you finding that they disagree? Those are all important components for your summary. And then for study quality and gaps in clinical relevance, those typically, I mean, you can think about those separately if it helps to think about kind of stepping through this. Those typically come up in, I know this table just exploded, in the critical appraisal piece, but keeping in mind at the top here, we have summary and critical appraisal. So we still have our two kind of main areas intact. Again, this is a monster slide, but hopefully helpful to come back to after the fact. So the critical appraisal piece, for the conflicting evidence, in the summary, we pointed out, hey, there are some patterns we're observing. You can see in the critical appraisal piece, that's where you're starting to come in and you're saying, well, where and why do these studies disagree? And you're coming up with hypotheses. So the example here is evidence generated by different clinical trials on the same topic may be conflicting, and it's up to you to hypothesize why they might be conflicting. And we'll talk about that in a second and then later on, but one reason might be because they were run on different patient populations, or maybe one of the trials was run much longer than another trial. And that you start to dig into some of the study methodology in a way, which is why we started this lecture talking about some of those primary research methods, because you might look at the conflicting evidence and be like, well, that study has 10 people and that study has 100 people, or that study was an RCT, randomized control trial, and that study was observational. And so knowing kind of some of the nuances of the primary research better equips you to come up with the hypotheses in your narrative review for why you might see some of the evidence disagreeing with one another. I hope that makes sense. Study quality. Are the studies well designed and reliable? So an example might be the number of participants, and these are real world kind of quotes pulled from the references on the right. So the number of participants in the included studies was small, which could decrease the power of the studies. So you might be saying, well, that's great. These 2 or 3, 4 studies agree with one another, but I'm critically appraising what's going on here. That's what my job. I'm summarizing and critically appraising, and I'm saying, well, okay, but I don't feel great about this because the sample sizes, the patient populations are really small. And coming out the other end of that, you might say, we need to do more research with much larger patient populations. Hopefully some of these narratives are starting to kind of click into place as I repeat them a little bit. Then identifying gaps, exactly. So what don't we know? Maybe the historical lack of data for elderly patients results in a knowledge gap. So you might be looking at a body of evidence and you've summarized it and you're saying, well, that's great. We know a ton about Crohn's disease in females of all ages and in elderly males. And wait, we actually don't know anything about Crohn's disease in males between the ages of 20 and 35, for instance. That's identifying gaps in clinical relevance. Does this matter for patient care? So a finding may be statistically significant, but long-term follow-up is needed to assess whether it's clinically significant. So we all know that things can be statistically significant. We might observe, hey, your A1C values are wildly different now, but does the patient actually feel different? Does that have an implication for kind of the progression maybe of their diabetes down the road? So thinking kind of second order, not just, oh, I saw a thing and it happened, thinking like, does that matter for more important consequences down the road? Would it affect how we treat that patient? Would we give them more interventions? Would we, things like that. So a monster table, again, I'll make sure these slides are shared out. And if you have questions before next week, feel free to let someone, myself or someone at IMG know if you do have a second or two to review these tables and you're like, this makes no sense. Let's stop for a second and hash it out. So talking a little bit more, our summary piece or critical appraisal piece, talking more about the critical appraisal piece, since again, summaries are table stakes. Everyone here does not need a lengthy explanation of how to summarize information. The critical appraisal piece, so all research and especially primary research, that new going out and gathering new data, it has limitations. And it's as part of your review, it's your job in that critical appraisal piece to point out those limitations. And these limitations come up all the time. If you have done primary research, just like absolutely anything in life, you go out there with a plan and you're like, here's my plan, here's how many patients I want, here's the time horizon, how long I want to run my study for, all of these different kind of ingredients for your research recipe. And like most things in life, exactly what you want to do certainly does not end up being exactly what you get to do. And inherently that introduces limitations to your research, which may affect the outcomes. Ultimately, you might say, I want to run this trial for 10 months, is how I want to do it. And then maybe your funding sponsor or someone goes, no, you're going to run it for 3 months. And you go, okay. But you know that that might not be long enough, for instance, for you to observe exactly what you would want to do from a clinical perspective. All right, back to the slide. So those limitations, for instance, trial may have to be cut short because of budgetary or logistical reasons. Maybe a study